over to Dr. Deepak Meghur sir for his presentation on learning nucleus bisection.
Hi everyone, I am going to talk on iridodialysis causes, prevention.
This is not the talk. Learning nucleus bisection by Dr. Deepak Meghur.
I have it. Can I play it? It's we have uploaded. It's called, I think.
Karthik,
You had a video. Can you play it?
Okay. Can I play it from my side?
Yes, doctor.
Hi, I'm Dr. Deepak Meghur, and today I'll be sharing new technique. This is about pre-chopping. I'm trying to use Dr. Khan's pre-chopper. This is used to just pre-chop the nucleus before removing the fragments. Okay, the principle here is, it is just like your horizontal phaco chop. Then using a very small vectis, the fragment is removed out of the eye using the phaco sandwich technique. I'm using a Chang chopper to go under the rexus margin, hook the endonucleus properly. The pre-chopper is placed at the proximal edge of the rexus, and then it is buried slightly deep inside, and then the two instruments are moved in a direction so that they come in contact with each other. This is the maneuver which results in the splitting of the nucleus, and we can feel a snap when it happens. And I usually prefer to do just two heminucleus. Each of these heminucleus will be not more than 4 mm in the widest part of its diameter, so it can usually come in a incision about 5 mm or 6 mm. I would avoid doing more fragments because managing these fragments with all sharp edges is going to be slightly traumatic to the corneal endothelium. So I don't see any much advantage of dividing them into very smaller fragments. Dividing it into two fragments is good enough for me. There are two aspects to nucleus management with this technique. One is, of course, dividing the nucleus using the pre-chopper. The second is manipulating these fragments out into the antechamber. Ideally, we would always want to have a 5 mm rexus. Well, manipulating out can be tricky, especially if you're dealing with a very large, bulky nucleus. Then probably a bigger rexus would be helpful, or even in a very soft cataract, removing these soft fragments out of the bag is going to be challenging. The technique which I use is I just use these two Msics, and then one pole of the heminucleus is tipped out, and then using the chopstick maneuver. Basically, we are supporting the fragment using these two Msics and gently lifting it out of the bag and keeping it in the antechamber. Then using a very small vectis, the fragment is removed out of the eye using the phaco sandwich technique. The chopper is slid horizontally so that the profile is horizontal now, and then in this profile it is slid under the anticapsule until it reaches the equator of the nucleus, and then it is rotated so that it goes in and hooks the equator of the endonucleus. So now we are sure that it is not above the capsule, it's under the capsule, and we can see the tenting above the anticapsule, just confirming this fact. Now with the second instrument, that is a pre-chopper, it is going to be placed at the proximal end just beside the rexus margin. The key thing here is that it has to be buried sufficiently deep enough. So the most important secret of achieving a good crack without inducing any torque, especially in such dense nucleus, is that both the instruments, that is the chopper at the distal end as well as the pre-chopper, the proximal end, they have to be engaging sufficient part of the nucleus. The Chang chopper has to engage the entire amount of the equator of the endonucleus, whereas the pre-chopper, it has to be sufficiently buried deep into the substance of the nucleus. And once we are sure that we are sufficiently deep enough, now is the time to move the instruments towards each other. And once it is done, we can see that the crack is done, but I'm not sure whether the posterior plate is also broken. So I just want to reconfirm it. I just rotate the nucleus a little bit and try to do the lateral separation using the same two instruments. I'm trying to place them inside the groove sufficiently and then try to separate them laterally so that whatever fine attachments are there holding on to each other, especially near the posterior plate, would be released. So in denser nucleus, it's obvious that the posterior plate could still be attached at some part, and go in, put in viscoelastic, and I'm trying to separate them using two instruments. OVD is introduced in between the two heminucleus inside the bag. This will help the bag to be well distended and the space is being maintained. Now is the time to prolapse each of these heminucleus out of the bag and then extract them out of the eye. Using two Msics hooks, I'm trying to manipulate one of the heminucleus out of the bag. As I'm trying to do it, I realize that there are still some fine attachments which are ensuring that the other heminucleus is also trying to come out. A little bit of manipulation with the two Msics hooks followed by OVD injection ensures that the two heminucleus are separated. Msics hook and the small vectis and sandwich the fragment in between these two instruments and pull it out. The OVD is again refilled into the antechamber and the bag, and then the second heminucleus is manipulated out of the bag, and using the same two Msics hook, just holding on either side, I just pull it out. This was a very traumatic way of removing the nucleus out of the antechamber. Since the nucleus is quite dense, it takes some effort and the process is slightly slow before I get that crack. But point to note here was the nucleus was rotating. There is a lot of torque in place, and the reason simply was that the nucleus was very dense. The degree of torque is directly proportional to the density of the nucleus. That has been my observation. And the second point also would be that pre-chopper has been buried sufficiently deep into the substance of the nucleus. Maybe the torque would be slightly less. Time to assess the two heminucleus, and I suspect that the posterior plate must be holding on somewhere, so I'm using viscoelastic to go in and explore, and I see that the posterior plate in the central part is not totally separated, so into two heminucleus, and now is the time to prolapse each of them out of the bag into the antechamber and then extract them out.
I think my time is up. Thank you so much.
I think we are missing all the discussions all along because of the time factor. But I should discuss. I should say a few sentences about Dr. Deepak's video. It's a very gratifying scene, very gratifying steps, and that's going to change the way we're going to do surgeries in the future. Bisection of the nucleus, especially when it is so thick and heavy, within the capsular bag, is an amazing concept. And all the steps are taken to prevent the obviously weak zonular apparatus being disrupted or capsule being torn, and that's an amazing way, Dr. Deepak. Wonderful teaching videos. Thank you very much.
Thank you, sir.
Who is online next? Mr. Karthik?
It's Professor Dr. Suresha AR. He's a professor of ophthalmology in Davangere Medical College. He will be speaking on surgical induced astigmatism. I invite Dr. Suresha AR to give his talk.
Good evening. I would like to thank KOS for giving me this opportunity. My topic is surgically induced astigmatism in MSICS. I have no financial disclosures. The astigmatic change introduced due to the surgical treatment of the cornea is called surgically induced astigmatism. Average SAA with conventional MSICS ranges from 1 to 3 diopters depending on the size of the incision. Main factors influencing SAA are intraoperative factors. These include incisional size, site of the incision, configuration of the incision, and wound stretching during the surgery, suture placement, scleral cauterization, intraocular lens tilt, and also laterality of the eye and position of the surgeon can also contribute to the SAA. With respect to incision size, a 4 mm scleral incision can induce 0.375 diopters of SAA, whereas 8 mm scleral incision can induce SAA of 2 to 2.5 diopters. So this is one of the main advantage over phacoemulsification. Here this can be utilized to neutralize the pre-existing astigmatism. So any incision which are made within the astigmatic neutral funnel are astigmatically neutral. With respect to location of the incision in SICS, either it can be temporal, superior or superiotemporal. Now it is a well-established fact that temporal incision induces about 0.3 to 0.5 to 0.6 diopters less SIA compared to superior incisions. Regarding types of scleral incision, these can be convex to trapezoid. So convex incision induces maximum SIA, whereas chevron incision, which are placed within the astigmatic funnel, induces the least astigmatism, surgically induced astigmatism. Regarding configuration of the sclerocorneal wound, to get consistent result, a proper construction of the wound is essential, starting from the scleral incision, construction of uniplanar corneoscleral dissection, tight pocket construction, and entry into the anterior chamber. So the initial entry should be parallel to the external incision and limbus. If the entry is not parallel to the external incision, the internal incision will run in the wrong direction. If the internal incision extends to the sclera, the corneal valve is lost and it induces more SIA. Pivotal tilt is not a significant factor in the present day surgeries. A 20 diopter IOL must be inclined 10 degrees from the vertical plane to cause 1 diopter cylinder. So we conducted impact of modified incision on SIA in MSICS. Our main aim was to attempt to reduce SIA by placing U-shaped 4.5 mm scleral incision within the astigmatic neutral funnel. So this includes 61 eyes of 61 patients having various grades of senile cataract. So only modifications which we followed in our surgery I would like to highlight. We took incision in all the cases at 12 o'clock position. Incision is placed 2 mm away from the limbus. Width of the incision was 4.5 mm and it is U-shaped, placed within the astigmatic neutral funnel. And the chord length of incision was same as regular SICS from 6 to 8 mm. In all cases, scleral cauterization was avoided. And one more thing is corneal dissection was about 1 mm, which is dissected parallel to the limbus. While doing entry into the anterior chamber, peripheral extension was stopped 0.5 to 1 mm from the sclera. SIA was calculated for all the follow-ups using SIA Calculator version 2.1, a free software program available online. So these are the results of our study. At the end of 1 week, SIA at the end of first week was 0.43 plus or minus 0.13 diopters. At the end of 6 weeks, SIA reduced further to 0.29 diopters plus or minus 0.2 diopters. In this, you can see nearly 70% were less than 0.25 diopters and nearly more than 95% of our cases achieved less than 0.5 diopters of SIA at the end of 6 weeks. With this, I would like to conclude. proper construction of the wound with placing the incision within a stigmatic funnel with width less than 4.5 millimeter, preferably temporal incision or on steeper axis and maybe within with nucleus bisection. A consistent phaco-equivalent SIA can be achieved in MSICS.
Thank you, sir. That was a great presentation. I invite upon our chair, sir, Dr. M.S. Ravindra, sir, to present SICS implanting Touring and multifocal lens in SICS.
Can I
Over to
share
MS
the
Ravindra,
screen?
sir.
Yeah, I'll share the screen. Is that visible?
Yes, sir.
Yes, sir.
It's visible.
Yes, sir. Visible.
That's an intumescent cataract, and the bag is very tense. Basically, the patient has come for a multifocal lens. For this patient, the biometry itself is going to be difficult because there could be differences, and as far as possible, do all kinds of biometry at least with two machines so that you have accurate. And I calculate the biometry based upon Barrett 2 1. And there are many ways of doing the surgery. I'll go fast. What I'm doing is about 2 less than 3 millimeter can opening right in the center. Is a tunnel floor entry where the AC is filled with viscoelastic and it doesn't leak, so there is no question of shallowing of the AC. I'm disrupting all the holes that I had made, as you can see, and aspirate the cortex as much as possible. This is one of the technique, but there are many techniques. I'm just go a little fast here. Enlarge it. These are direct incisions. There is no congenital flap, and incision starts on the scleral side of the anterior sclera. And now I'm going to do rhexis with the Utrata forceps. It's going to be a smaller rhexis. I'm always scared of the rhexis running off to the periphery. It's a very obese man with very heavy breathing. You can see the eye and face, everything is moving continuously. But I could achieve a rhexis of that size, but it's impossible to remove the large nucleus through that. So I'm going to do another rhexis, make it little more larger. I have to retain the rhexis here. So maybe repeatedly I've injected viscoelastic into the anterior chamber. I could get a good rhexis, and now I'm sure that I'm going to implant multifocal lens in him. I had an option of a standard lens also. I've discussed with the patient, and intracameral lignocaine. It's a topical anesthesia surgery. Rotate the nucleus and lift one pole. I don't do hydrodissection in a mature cataract like this. Lift bisect it and remove each piece separately. Aspirate the cortex, which is very important in any cataract surgery because leftover lens matter can give rise to. And to keep the integrity of the lens, I slit the top of this thing. That's the injection of a multifocal lens. The question comes whether multifocal lenses can be implanted in a SICS. That's a commonly asked question. Yes, I would say, if you have a control on how much of astigmatism we're going to produce. Most of the people have against rule astigmatism with the steep axis horizontally. So you can mark the steep axis and implant it. So as far as toric lens are concerned, it's very important to get the absolutely nice toric power. See, this patient has 3.75 on the AR, and on the cornea is 2.25. You're going to correct the 2.25 there. And how do I go about? It's at 90 degrees, fortunately, exactly. The steep axis at 180 degrees, very, very convenient for me to operate on this side. And there is a gadget here, this is called AL scan, which gives a picture. Then you can actually see a loop of the vessel there. So this is a steep meridian, which is at 3 degrees, and flat meridian is 93 degrees. So I can rotate the, so you can, this is a steep axis, you can rotate the green axis to align to this. It's going to happen now. And the patient should be seated there with the chin rest. Ensure that the patient's head is straight. And now you come to this screen and move the That's a loop there, which you can identify during the surgery. I can move it and align it to that. That means in the surgery table, I'll have to, from the bend of the loop, I'll have to make a 38 degrees to identify the strip axis. It's a very convenient, very accurate way of doing it. You can move it by 33 degrees as per the chart here that you can write down and keep it with you. These are the OPD3 scan readings where you can get all the data on the cornea, and this is on the refractometer, that's on the aberrometer. All the data can be obtained here, and you'll have to match all the readings, steep axis and flat axis readings that you get here on various platforms, including the ARK reading, and then you can match that by Barrett-2 calculations, and you can choose, and better to make notes like what you have here. Where is the incision placed? Incision should be placed on the strip axis, and 177 degrees. 38 minus 3 degrees is going to be, or 5 degrees is going to be 33 degrees shift. So calculating the actual point at which you're going to start the incision, and understanding your SIA, and positioning of the lens inside the capsular bag, all are very important. And at the end of the surgery, like you're all familiar, the entire viscoelastic from the capsular bag has to be removed. And at the end of the surgery, when the eye is pressurized, there could be some rotation of the lens that you'll have to watch it carefully and see that the markings on the lens are aligned to the axis that you're intending to put it. With that, if you understand that what kind of incision and what kind of surgery produces how much of SIA, you will be able to comfortably put both toric lenses as well as multifocal lens of any type inside the eye after an SICS. Thank you.
Thank you, sir. Now I invite upon Dr. Shilpa Malid for speaking on SICS in hypermature cataract. She is a senior consultant at Joshi Eye Hospital, Hubli. Over to Shilpa.
Good evening, all. I would like to thank QuasCon and ISMICS Society for this wonderful opportunity. Hypermature cataracts are not so desirable because of their notorious behavior intraoperatively. We have to have a strategy to deal or have an attack on the associated multiple hurdles during the surgery. So first of all, there is absent red reflex. The second thing is there is raised intralenticular pressure. The capsule, which is fragile, wrinkled, calcified, and at times fibrous with the associated posterior signing. Also, on puncturing of the anterior, having to deal with the milky fluid that oozes out, disturbing the visualization. Also, like a Pandora's box, when we open and aspirate the fluid, we may have to face a very small, tiny nucleus or a thick, dense, leathery brown cataract, like a Pandora's box. Important thing here is because of the long-standing nature of this cataract, the zonular apparatus is weaker comparatively to other types of cataract. So there are only two strategies we should have before starting the surgery. One, and the first thing is absorption or washing off the turbid milky fluid from the anterior chamber for good visualization. And the second thing is the capsulotomy and the nucleus management has to be done in such a way that we are not further jeopardizing the weaker zonular apparatus. So without wasting time, let me take you through the compilation of my own videos. So here is the first video where you can see a very simpler absorbed hypermature cataract, sclerocorneal tunnel construction of adequate size and desirable shape of a surgeon. We are going to fill the antechamber with the viscoelastic substance. The initial nick onto the antecapsule has to be done where we are seeing the nucleus, not away where we are seeing a good glow, as it is very easier to puncture the posterior capsule as well along with the anterior capsule. And the further continuation and completion of the capsular excess is done with the help of Utratas forceps. These nuclei are very easy to deal with. There is no fluid, there is no denser nucleus. It simply glides out of the sclerocorneal tunnel. You're implanting an IOL and you're done. This is a case where we are supposed to be worried. There is a lot of milky fluid. After ooze, now we are not seeing the tone capsule. So what we can do is hold an irrigation port. This is a visco cannula which is mounted onto a phacoemulsification irrigation tubings. Note the direction. It is away. It is towards the iris. It is not onto the top of the nucleus and the fluid. So the completion of rexus is simpler and the flap is not cluttering into the anterior chamber. If we don't have an access to phacoemulsification muslin, there is another way. That IV tubings, what we are using for Simcoe cannula, on that only what we can do is mount a cystotome and titrate the flow as per your need, and then you can complete the rexus. Here, fluttering of the flap is very common after completion of around half to 2/3 of the capsular rexus, and there are high chances that the free floating flap may just prolapse out of the side port, tearing it to posteriorly. So it is wiser, if that is happening, to shift to a Utratas forceps and complete the rexus, as you can see later on. Another important thing is to deal with the nucleus management in such cases. It is a very good idea to use a wire victus, either a irrigating victus or a wire victus, simple wire victus, which can be used as a sandwich technique. Visco expression will further weaken or will let the zonule stretch and have zonular dehiscence after the nucleus delivery, leading to complications. My next case is, if you don't want to use both either of those means, then what you can do is a simple humbler instrument called as AC maintainer. Anterior chamber maintainer can be inserted through another side port, which is planned at inferiorly at 6 o'clock. The flow is titrated. It is very slow flow so that the flap doesn't flutter as frequently as you had seen in earlier two cases. And the next cases as we have planned. Sometimes traumatic cataracts tend to be at a hypermature stage with posterior synecdoche and fibrous anterior capsule. Here with the spatula, we could not release the synecdoche. So the micro scissors are being used. Here we are going to push the iris and snip the synecdoche. If we pull it towards the center, then we might end up having a iridodialysis. Also, the initial nick onto the capsule has to be done in such a way that we are avoiding the fibrous capsule. The tone capsule now is being pulled tangentially so that onto the zonules as you are seeing. Then if possible, we can complete it. If not, then we have to snip it off with the scissors. Then another case, a very, very long standing hypermature cataract. You can see the dense turbid fluid. After the initial nick, I had to wash up the fluid, inject visco and complete the capsular rexus. But what you are seeing is, to my surprise, those were the calcium plaques which were lying there in the capsular bag. And those I had planned it a phacoemulsification surgery. Later on, I converted it to a small incision cataract surgery. What happens if you try doing a phacoemulsification in such cases is, here you are seeing the nucleus tilts. There is no support. It keeps on tilting and jeopardizing a weaker zonular bag. So it is always wiser, whatever top end phacoemulsification machine you have, or however good femto cataract suit you have, it is always a wiser and simpler to attack such cases with a small incision cataract surgery. Thank you all.
Thank you, madam. A good message conveyed. I invite Dr. Venkatragava sir. He is a senior consultant, Global Foundation. He will be speaking on SACS in hard cataract. Over to Dr. Venkatragava.
So good evening all. First of all, I'd like to thank Team KOS, Dr. Naneshwar, for inviting me to this talk on SICS in hard cataract. And a special thanks to our senior mentor and our sir, dear sir, Dr. Sundaram Shetty. I'll be sharing his videos only to present on the how we deal with the hard cataracts. So quickly moving into the presentation. So, a very good slit lamp evaluation is very important before we choose to operate on the hard cataracts. So here in this presentation, I will be dealing with only hard cataracts without any pre-existing conditions such as pseudoexfoliation or zonular dialysis, and well dilated. I have selected all well dilated pupils. So here at GEF, we modify the nucleus to suit the tunnel size. At GEF, we do a tunnel which is biconcave, which is situated in the superior temporal quadrant, which is around 6.5 mm in length and 1.5 mm width on either side of the mid-limbal line. So we keep the tunnel side constant so that we don't have any astigmatic surprises post-op. And we do a nucleus bisection. I will be showing in videos. These are the two instruments we use to mobilize the nucleus out of the capsular bag. So this is the iris repositor and the dialer. We mobilize the nucleus out of the bag and into the anterior chamber. These are the two instruments. This is a vectis on the one side and the other side as an iris repositor, and this is the dialer. These are the two instruments used to manage any kind of cataracts. And this is a vectis, which is a teardrop kind of a thing, which is broadest at the tip. So going to the first video. This is a hard cataract. Its nucleus is already mobilized into the AC. The vectis goes behind the nucleus. What we do is gently score over the nucleus and do not require too much of a pressure. So suppose if visco is coming out, don't hesitate to come out and replenish the visco. Okay. And it is bisected. It is bisected. Then with the same two instruments, that is a repositor and the dialer, we just separate the nucleus. It is better to do a scissoring motion to separate the nucleus. Once it is separated, once again, if needed, replenish visco and bring one part of the heminucleus to the center of the tunnel and deliver one after the other. So whatever hard it is, however hard it is, it easily can be bisected. And this is the, sorry. See, after hydro, we mobilize the nucleus. We just push with the dialer so that the edge of the nucleus is felt, and bimanually with the repositor and the dialer, we mobilize it into the anterior chamber. So once it is out, then the dialer gently is held above that, and the vectis is passed underneath the nucleus. Don't hesitate to pass the vectis. We hesitate, then we lose the chamber and we have to replenish once again. So you see here, as you see here, the broadest part of the vectis is in the center. It is engaging the center part of the nucleus, and the tip of the vectis is just beyond the center of the nucleus. And the similar way we bisect it and deliver it one after the other. Oh, this video is not playing, sorry. And this is one more. This is an old video. So without, we are doing it without the, or what is trypan blue. See, so bimanual nucleus mobilization into the AC. Once it is mobilized, so here I am showing the steps of only the nucleus management, because this is the most toughest part in managing the hard cataract, and other steps have already been discussed earlier. I'm sure Deepak sir would have discussed more about the bisection in the previous talk. See here, and actually this kind of dimpling on the cornea should not happen. This is not the ideal situation. So once you see that kind of a dimpling, it is better you come out and regroup, plan it, put some more visco and go to the center of the tunnel, put the vectors underneath. Before putting the vectors, a slight lift or the edge of the nucleus so that the vectors easily passes. Vectors should always be the broadest part of the vectors should hold the center and the most center part of the nucleus. Here the scoring should be done gently over the nucleus until we touch the tip of the vectors beneath. Then bisect it as shown here and remove one heminucleus after the other and make sure that heminucleus is at the center of the tunnel and use the full length of the tunnel to deliver the nucleus so that there is no damage to the tunnel. So here all the videos have been done using HPMC, but I would recommend use cohesive visco so that least damage on the endothelium and the chamber is very well formed. And next there is one more video here. So here you can see how we mobilize the nucleus from the capsular bag into the AC. You see here, this repositor is holding the capsule and it is preventing iris and the capsule coming towards the center. And this dialer is pushed peripherally so that the edge of the nucleus is visualized. Once the edge is visualized, so then we bimanually rotate it so that it easily slides into the anterior chamber. So this is a very effective way of mobilizing the nucleus into the AC without damaging the capsule or the iris. This is a very hard cataract. So the broadest part of the vectors was in the center and it almost got separated. So replenish with visco and with the same two instruments, that is the dialer and the vectors. It is better to separate these two with the scissoring motion as shown it as we have shown it here. Once it is totally separated, replenish with visco and bring the one heminucleus to the center of the tunnel, deliver it, followed by the second one. Always use the full length of the tunnel to deliver the nucleus. You can see how neatly it has been bisected. This kind of clear break happens when we exactly break at the suture lines in the nucleus. However hard it is, it surely breaks with the dialer and vectors. So my take home points is at GF, at least we modify the nucleus to suit the tunnel, and that is the ideal way of doing it as we believe it, and use cohesive viscoelastics so that the chamber is formed and least trauma to the endothelium. And for the beginners, the tip is so to bisect in all the cataracts, that is even if it is NS1, 2, you bisect so that you get a hang of it. And we do only two, we break it into two pieces, not more than two, so that there is no sharp edges which can damage the other intraocular structures. Thank you.
Thank you, sir, for your useful tips. We will now move on to small pupil SSCS by Dr. Mallikarjun sir. Over to Dr. Mallikarjun sir, please.
Thank you, so scientific committee of KOS for giving me this opportunity. I'm going to talk on small pupil management in SICS. These are the various methods we can use in management of small pupil in SICS. Stretch pupilloplasty with Cugnan hook. Usually I don't use and I don't have any experience of doing it. Sphincterotomy, it is better to do multiple sphincterotomies, smaller ones in all quadrants, so that people will expand in evenly in everywhere, and we can do the surgery easily, and also the people will remain smaller post-operatively. We can also use high viscous viscoelastics to expand the people during surgery. In every step, you have to inject the viscoelastic so that people will expand and it will make the surgery easy. And also we can use iris hooks and pupil expanders as well. This is a video where I'll show iris hooks in SICS. First make a section and don't enter into the antechamber and make a 4 stab incisions, not making the longer bevel, and then enter into the antechamber. And here I'm staining the capsule with either trypan blue because it's a intumescent cataract. Now inserting the iris hook. First insert the iris hook, engage at the pupillary margin, and then don't pull it. After inserting all 4, then pull the iris hooks. Since it is the intumescent cataract, I'm doing the double rhexis. First I made a smaller rhexis, remove the cortex, and going ahead with the second rhexis. And gentle hydrodissection here. And I remove the 2 iris hooks at the section so that the iris will go back and it will make a subsequent steps easy. So I cross the nucleus in the antechamber and delivering the nucleus with a wire vectis. And after that, I again engage the iris hooks at this section so that pupil will remain expanded. So cortical aspiration and intraocular lens implantation easy. This is a big lens, 1-piece PMMA lens, and still I can see the most of the lens and dialing it into the bag. I can see the intercapsular margin also. Removing the iris hooks is very easy. You have to disengage at the pupillary area and pull it from the stab incisions. It will come easily. This is how it looks post-operatively, immediate post-operatively. Although it looks ugly, it may remain smaller post-operatively. This is how it looks post-op 5 hours. This is one more video where I'll show pupil expanders in a small incision SICSD. Pupil expander can be inserted in the antechamber using Simsky hook or McPherson. Then using 2 dialers. One dialer you use to engage the pupil expander and other dialer to disengage the iris. And in same way, I am engaging the pupil expanders in all 4 quadrants. First, I engage with one Simsky hook and disengage the Simsky hook with other Simsky hook. This is a hypermature cataract. I can do a bigger rhexis and prolapsing the nucleus into the antechamber. All the cortical matter came out first, so I'm removing it with viscoelastic first. Then with help of 2 dialers, I plug the nucleus into the antechamber and subsequently deliver the nucleus. And cortical aspiration. So you just notice that the pupil expander has not disturbed it. So removing is very easy. Just you have to using the dialer, you disengage the 4 areas of the pupil expander. So now it is into the antechamber. With the help of MagForcing, you can pull it, it will come easily. And removing the viscoelastic. Thank you.
Thank you, sir, for the wonderful presentation. The last talk would be of this session would be by Dr. M.S. Ravindra, sir. He will be speaking on the difficult topic and a difficult surgery SICS in iris coloboma. Over to Ravindra, sir, please.
Bilateral typical coloboma. The other eye was operated 2 days ago. Entry at the steep axis. Translimbal direct entry into the antechamber with a 2.8 millimeter keratome. HPMC injected into the anterior chamber. The cystotome enters the anterior chamber, perforating the floor of the tunnel at the limbus. The rhexis starts from an area clock hour beyond the colobomatous area, as many times colobomatous area, the rhexis would be difficult. So that will be the fag end of the rhexis creation. It's a good rhexis without any untoward effects. Single entry into the eye, there are no side ports needed. Hydrodissection is done away from the colobomatous area. Starting from that, it's a capsular separating hydrodissection. The nucleus is gently rotated into the anterior chamber. It's bisected, and each piece of the heminucleus was removed from the eye between a 25 gauge cannula, which is continuously injecting visco to separate the moving nucleus from the endothelium, and supported by a mini wire vectis. It's a very tiny wire vectis, and the other half is also similarly removed. Pieces of epinucleus can be visco expressed, as you see now. It's very important to understand that this technique is outside the capsular bag, so there is no pressure or a pull applied to the capsular bag or zonules throughout the procedure. The entire nuclear management is in the anterior chamber. The cortex at the colobomatous area is handled at the end of the cortical aspiration using Simcoe cannula. The subincisional cortex can be aspirated with a J-shaped Simcoe cannula, which comes in a pair. This is a right-sided J-shaped cannula. The visco is replenished into the anterior chamber repeatedly. Very carefully, the cortex at the colobomatous area is aspirated, and the area is polished. It will usually have few adherent spots of opacity, and sometimes it will have deficiencies. That's the reason it should be handled at the end. Sometimes vitreous fibrils are seen through defects in the capsular bag in the colobomatous area. That is the area where many times herniation of capsular bag occurs. Carefully, that can be avoided by very gentle manipulations. Lens is introduced into the capsular bag. I take the advantage of keeping the wider haptic optic junction in the colobomatous area so that it can minimize the glare that can occur. As you can see here, the wider portion of the haptic optic junction, the base of haptic actually is positioned at the colobomatous area, and postoperatively I see that the patients are going to be much more comfortable because that area is now occluded by the light which gets deflected elsewhere onto the retina instead of the macula. This is the other eye which was operated 2 days ago. You see that the haptic base is occluding the coloboma and the patient had much lesser glare. Also note that the visual axis, the Purkinje-1 image is within the pupillary zone. If the iris had blocked that area, I would have made a small, tiny incision, a sphincterotomy in the occluding area. A photograph of the eye taken preoperatively would be of great use during the surgery. Thank you.
Thank you very much, sir, for the nice presentation. We have around 10 minutes time for any questions and discussion.
Yeah, I think we have seen a wide variety of procedures, a lot of techniques, and that just means that SICS does not mean one standard method. There are as many methods as there are surgeons. And ultimately, I think the highlighting is that right from the beginning, it was suggested that topical anesthesia is the best. Topical anesthesia is compatible with any kind of the SICS, and temporal approach is better for various reasons. It'll reduce the SIA because most of the patients at that age group have the Against rule astigmatism, where the steep axis is going to be horizontal. And SICS has certainly many advantages. The number of instruments you need is much lesser, and they're all very convenient. Comfortable for the staff to autoclave and bring them. So every set is autoclaved and fresh instead of reusing the various instruments that can happen when you are using expensive gadgets. These are a couple of things that I can think of. And one major difference between SICS and any other technique is that here you don't have to bargain on the incision size. You can have a comfortable incision size, and never try to compare with smaller incisions that are very compatible with phacoemulsification. Here, you should go in for a larger incision so that you don't damage the endothelium. The target, I keep saying all the time, is that the endothelium has to be pristine. And when you have endothelial count, whenever I change my technique, I carefully wash the endothelial cells. And if there is a loss, it can happen, it will happen in every hand. If there's a loss, we'll go back and review our technique as to how to modify it. So these are a couple of points that I would like to highlight. And as I said, never try to reduce the size of tunnel, and use that to your advantage. You can have a 6-7 millimeter tunnel with 0.25, 0.5 SIA if you modify as earlier discussed here, and don't try to make it smaller and smaller. And what happens is you will compromise on the endothelium. This I have seen with my own experience. I've gone up to 3 and I've come back to 5 millimeter now. And as Dr. Deepak pointed out, the bisection of the nucleus, either in the capsular bag or in the anterior chamber, protecting the endothelium is paramount importance if you want to respect the tunnel, if you want to respect or have standardized SIA at the end of the surgery, so that you can put multifocals and toric lenses in your practice. These are a must in today's practice. If you're not implanting multifocal, toric, EDOF lenses, many patients are going to leave you, especially because of the thrust the industry is giving to this advanced thing. People come asking for multifocal lenses. You cannot really say, I can't do it. So there must be a way out to modify your own techniques and monitor your SIA in every patient. Have a preoperative care reading, postoperative care reading, and see how much a particular technique that you adopted has produced it. Identify the steep axis on the cornea. Even if you're not using a toric lens, identify steep axis and take your incision there. Toric marking, you do it even if you're putting a non-toric lens. To do a toric marking and use your incision as an advantage. And I learned many new things from my colleagues. There are many very interesting points that were put in. And age is not a criteria, experience is not a criteria from staying away from learning. And with this, we thank all the faculty who presented, who took time, presented beautiful videos and lectures in this forum. 3 hours went on like half an hour. So I again thank all the panelists. I thank the organizers. I thank the moderator. I thank the co-chair, Dr. Mallikarjun, and thank KOS and ISM SICS. So Dr. Dev Prasad, would you like
sir.
to add on?
It was
We can take another 5-10 minutes. There's still 8
if
minutes.
there are if there are no questions, then we can just conclude the session. It was an enlightening session, and we had a discussion on vast range of topics, ranging from the basics to the advanced, along with the prevention of complications and its management. I hope the delegates would have benefited by this extensive knowledge sharing. And I would like to thank Dr. Ellen Kumar for giving us a prime slot, 3-hour slot, that on the first day of the conference. And he has given, I also thank the scientific committee of the Karnataka Ophthalmic Society for giving importance to MSICS that which it deserves. And I thank all the faculty, the chairman, the co-chairman, and the moderators, Dr. Ganeshwar and everybody for running the session on time. Thanks a lot once again.
Dr. Dev Prasad, there's still time. I have a couple of questions written down here. Can I ask now?
Yeah. Sure, sir.
One
Go
is,
ahead.
Dr. Deepak, for when you bisect the nucleus in the bag, have you tried prolapsing them together? You try to separate them and prolapse them. Have you thought of or tried or attempted prolapsing both of them? But what I find is, if there is a limited size of the rexus and there is a large size nucleus, if there is a disparity between the two, so when I prolapse it intact, I see a lot of stretch on the capsular bag and zonules. So in that case, I bisect it and prolapse them together. Somehow by either flexing or by something, it becomes much easier. So now you try to prolapse them alternatingly, one first and one, and then you remove it from the AC. That's a good point because there's not much of material in the AC at that point of time. So what are your thoughts on that?
It has happened unintentionally when the fragments were not separated together totally. Sometimes that come together, but I think it was always better to separate them totally in the bag and then get out, because with the smaller axis also we can come out. There's less of a lens matter. It's easier for it to collapse out. When some part of it is attached, it is neither totally in toto, which comes in very smoothly when you rotate it. It doesn't come like that, so it's a little bit uncomfortable and cumbersome. That's what I feel. So either you prolapse it in toto or divide it totally inside and come out. So my preferred choice is always going to be separate them totally and then come out. Unintentionally, in a couple of cases, it has happened where the posterior plate had not cracked, and when I tried to remove one piece, the second piece also followed. So what happens is there is some amount of uncontrolled drag on the rexus margin because other is floating around. It is not like that. So I would not prefer to have this. I would rather prefer to separate totally and come out.
It's very interesting. What all I have tried all along is I bisect only the nucleus completely and remove the entire piece out of the capsular bag. It's much easier even in a case of small rexus. And then complete the bisection in the anterior chamber and remove it. This is what I've been trying. I'll certainly try the technique of completely bisecting in the bag and taking it out one piece by another.
There is a little bit modification, sir. Here we used to rotate and get it out, no? You can't rotate there. So you have to separate it totally, then use the two instruments, then pick it up and then just come out. Correct. You can't use the rotation force here to wheel it out of the bag. That has to be unlearned now.
Okay. So the Mallikarjun, I don't see him here. Is he here? Okay, anybody can else take. What will be the distance between the limbus, blue limbus, to the entry of the incision you make to fix the sutures for the iris or whatever it is? So it's 0.5 millimeter, 1 millimeter, 1 point. He showed a video wherein he didn't mention.
It has to be 1 to 1.5 millimeters, sir. 1.5.
Great. And the other thing is, if it's a small iridodialysis, is there really a need to fix it up? You can just cosmetically, it's not bothering you. It's a black iris anyway, brown iris, and people is adequately open and D-shaped. And just because the dehiscence in the attachment of iris is there to the root, do we have to go and meddle with it or just leave it there?
No, sir. I think one clock hour or 1 to 2 clock hour, you can just leave it. As long as the pupil is not overhanging or coming down, it shouldn't cause a problem, I think.
Okay. Dr. Shilpa, do you do as a routine hydrodissection in all mature or mature cataracts, or you don't do it?
I prefer doing it, sir.
Okay.
Still, I believe that there might be some posterior synechial adhesions which might end up troubling the posterior capsule and zonules.
The only hitch is how do you take care that you're not going to break the posterior capsule because you're not seeing it. How much of fluid goes inside is not being visible by the illumination, by retroillumination.
Yes, though the procedure is a blind procedure, I make sure that I'm making the anterior chamber a little shallower than routinely, so that it doesn't, even if unfortunately there is a posterior polar cataract or weak posterior capsule, I make sure that I tap onto the posterior scleral rib so that AC is little shallow, and even if there is a PCR, it will come off. It won't sink down.
Now, what I follow is I don't do as when the wave is not visible. My dictum is I won't do hydrodissection. Instead of hydrodissection, I hold the nucleus with two instruments and rotate them. It's as good as hydrodissection. Hydrodissection happens in a plane between the cortex and the capsule. Here, the plane is going to be between epinucleus and the cortex. It doesn't matter. So, but at least you're sure that you're not pressurizing the capsular bag, which is already tense because of the large cataract. And that's my policy. It's worked well in my hands. So there are many ways of doing it. So I would always say that don't do hydrodissection in any hypermature large cataract where you can't see the wave.
So if there is fluid in hypermature, I won't be, sir. But if it is only mature cataract, I prefer to do it. Somehow
But
I prefer to do it. I'm a little apprehensive without hydro procedure rotating the nucleus. It
you
works
just
beautifully in
rotate
your hands.
you rotate the nucleus, and that itself is separation of all attachments. So that's what I would like to just try it out if
Definitely, I'll do it, sir.
so I think we still have 1 minute. Any other comments, Dr. Shilpa, Dr. Deepak?
Yeah, I wanted to ask Deepak, sir, from where he got those instruments of bisection. Dr. Deepak, sir, is not there, I guess.
It's Dr. Khan's instruments, and he has devised this the pre-chopper. There are two pre-choppers, one for soft cataracts, other is for hard cataracts, and that they're very elegant instrument. They are available now. He is the inventor, and he's got a trademark on it, and they are available.
How do we get it? I mean, which company, or how do
There's
we
no
order
company.
it?
I think you'll have to talk to him directly. Sohail Khan is the name, Dr. Sohail Khan.
Yes.
And I can
Okay.
share his phone number. If you write it to me, I'll share his phone number. Remember Sohail
Definitely,
Khan?
sir.
He is everywhere on the.
Yeah, I know him, but I don't know that he has
He has it. If
invented
you know
those.
him, then he will help you with the instruments.
Definitely. Thank you, sir.
Again, thanks to everybody, and thanks to ISM SICS, and thanks to KOS, and for this wonderful opportunity. Good night. Have a nice day.
Good night.
Good night, sir.